So we are at 3 after, so we will go ahead and get started because I know everybody here is busy and I want to allow us some time for conversation a little bit at the end and to be able to answer any questions that we have. So what I will say in this, so if you enable your chat during the conversation or during the webinar today, please feel free to put comments in the chat. We will have a more open time later at the end to answer some questions based on that as well. But welcome everyone to our webinar today on the standards for medical respite and recuperative care, an overview of the 2021 update. For those of you who don't know me, I'm Caitlin Sinevec. I am the program manager for medical respite with the National Institute for Medical Respite Care and the National Healthcare for the Homeless Council. So I'm very excited to be here today to share with you about our new standards and ways that you can really work and apply them to your program here. We just want to acknowledge HRSA has funded this project here. And here's an overview of what we're going to cover in today's webinar. So we want to talk about what the standards are, how are they updated so that we have a lot of transparency around how they were developed and who contributed to that process. Going to share what the standards are, really the key point, the meat of this conversation today, and then also review some of the changes for those of you who are more familiar with the 2016 standards, making sure you can see where some of these changes and revisions were made. And then we're going to talk a little bit about how to apply and use the standards in your practice, in your medical respite work. And then again, like I said, hopefully have a little bit of time to answer some questions and engage in discussion around the standards and using them and next steps. So hopefully by the end of today's webinar, you'll be able to identify what our 8 standards are and also be able to identify how you can apply and use them in your own medical respite program. So before we get started and jumping into today's conversation, I do want to get a sense of who's in the room here. So I'm going to launch a poll, especially since we're doing this webinar style, a little bit more formal. I would love to know what your connection is to the medical respite program. So answer just with what I know some people fill multiple roles. What is your primary role? Just kind of curious as to who's here today and how this information is hopefully going to be used. So we'll leave that up for a moment here. Wonderful, lots of medical respite program providers here today. Welcome, we're so excited. So we'll leave this up for just another minute. And I'm gonna go over now, we're gonna start this webinar really just talking about how these standards were revised. And before we do that, I want to just sort of lay the groundwork for some terminology. So the formal and official name is the Standards for Medical Respite Recuperative Care. You'll also see us refer to them as the standards. So when that's used in this context, we are using it to describe what the standards, the medical respite recuperative care standards. I will note that the terms medical respite and recuperative care are used interchangeably to describe the same service. My default often is to say medical respite, but please know that using that term encompasses both medical respite care programs, recuperative care programs, describing the same service. And for those who are not as familiar, we have the National Institute for Medical Respite Care, and our goal is to represent all medical respite and recuperative care programs. And in that case, then the standards are equally applied to all programs. And NIMARC is just lost the word. It's an initiative of the National Healthcare for the Homeless Council. So you'll see that our work is in collaboration with the National Healthcare for the Homeless Council. All right. So again, part of the reason why these standards were initiated is that there's so many variations and variables in our medical respite programs. So the information that I have presented here is based on the information that we have available in the medical respite directory. And so if you haven't updated your directory form, I'm going to recommend that you do that soon. And I think Stephen will drop that link in the chat here. It's really important because this is how we know what medical respite programs are and look like across the country. So based on the information that we have in our respite program, we know that about 30% of programs are based out of shelters. 30% are standalone facilities, and the remaining third are really just sort of a combination of different resources that are available in the community. There's a huge range in beds across programs. There's programs that offer as small as 2 beds, and there are programs that have expanded up to 210 beds. Most programs employ a registered nurse. That's the most frequently reported staff member, followed closely behind social work, community health workers, and then clinical providers such as nurse practitioners or MDs, as well as a large number of other staff members to kind of fill in these different roles. That's a lot of variability, especially in healthcare when there's a lot of sort of standard structure that gets used. And it is for that reason that we developed the standards to really help guide programs despite what type of facility you're in, who provides your clinical services, how many beds you offer, who you collaborate with, right? The standards are really applicable to all of us in these spaces. And even though these program structures really vary, we have these key features that make medical respite, right? That the person is at the center of all the services and care that we're providing, whether that care be clinical care, case management, integration into primary care, and supporting self-management. These are all things that get addressed in the respite program to really meet the needs and the goals of the person who's in that program. When we're doing that, and you'll see that sort of reflected in our standards here, that we're doing this in a client-centered way and that we're doing it in a trauma-informed way. So for those who are less familiar, I'm going to provide a little bit of a history of the standards. So in 2011, the steering committee of the Respite Care Providers Network identified that there was a need to establish these standards, right? For all of these reasons I've just listed in terms of variability, to have this really guiding document to be able to say, this is what respite care is. And so they identified, the task force was charged with developing standards that aligned with other health industry standards. So if you've worked in healthcare, you know there is the Joint Commission and there, all these other sort of agencies and organizations with rules that you need to follow, right? So we wanted something to be that was similar to those other standards, but also reflected the needs of the patients who are served in medical respite program. That's a lot of what makes respite and healthcare for the homeless different, is that our services are tailored specifically to this population. The standards also needed to promote quality care and improved health and be achievable for a range of medical respite programs with varying degrees of resources. And this is something that we know, that resources across communities is really variable, and that often what lends itself to what models people adopt. So we want to make sure and have continued to make sure that the standards are something that are achievable despite what your program might look like. So in order to do this revisions process, part of best practices is that really key documents are updated and looked at every 5 years. So in 2021, a work group of RCPN members was formed to continue the work of the initial task group. And the goal of this task group was to review the 2016 standards and identify revisions and additions that are needed. And that's because we know that there's new evidence and new best practices to incorporate, that there's new models of respite program, and that programs are continuing to develop across the country. So being responsive to changes in what's guiding that practice and care. And we also know that policy and healthcare system changes have happened. In 5 years, there's been an incredible amount of change, even in the past 18 months. So we wanted to make sure that the standards were continued to be that key resource and element that could guide programs effectively in healthcare systems as we see them today. So the revisions process, just to give, again, an overview of how we came about this final document that we're going to talk about today. The work group was developed in January 2021. There was an initial review and revisions proposed that resulted in a drafted update. That drafted update went for an external review, which included surveys from program providers, as well as a focus group with consumers. Many members of the National Consumer Advisory Board participated in that. All of this feedback was consolidated, including information from programs, consumers, additionally, original work group members and council staff. All were able to review this draft, and this information was pulled together for the next step of the revision, which resulted in a second version of the document. This version then was closer to final, and we were able to test these standards with existing programs, which was really important to help make sure what we wrote and what we were asking of programs was realistic and feasible to be implemented. And then we reviewed these results with additional program data and feedback, including some programs who'd completed the medical respite organizational self-assessment. Where do programs have trouble meeting the standards versus, what do we identify as best practices, and consolidating that together. That all resulted in the final draft that was reviewed, approved, and published in September 2020. Oh, no, September 2021, my goodness. Not next year, but it was approved this current September for publication for programs to be used. What is really exciting about this process is that there was representation from over 30 programs in the revision and development process that reflected geographically and programmatically diverse perspective. And I think that's really critical in thinking about this document's usability for programs, is that we had so many different people really contributing to this process to really make sure it was reflective of best practices. I also really want to especially acknowledge our work group members, Brooks-Ann McKinney, Brandon Cook, Leslie Enzian, Liz Locatelli, and Mariah Nunnally as the work group, who really came together outside of their day-to-day work and thoughtfully considered and worked through each statement and criteria that you will see here. So all of this work was done really intentionally and over this period of time to make sure that they were robust, comprehensive, and again, reflective of what we want medical respite care to be. So now I'm going to get to the structure, the standards. What are they? So there are 8 standards, and you might notice that this is one change in difference from the previous version that had 7 standards. There are now 8. I'm going to get into sort of the details of that in a moment here. Within each standard, there is criteria that defines what it means to meet each standard. So the standard is that broad overarching statement. Each one of them includes several criteria that sort of tell you what it means to do that, what it means to have this standard of care. So standard 1 is the medical respite program provides safe and quality accommodations. So medical respite programs provide patients with a space to heal and rest and perform their ADLs while receiving care to recover from acute illness and injuries. As such, the space of the medical respite program should be habitable, support physical functioning, hygiene, and personal safety. So this standard really focuses on ensuring the quality of the environment for the medical respite program, consumers, and staff. This includes criteria regarding safety, processes for emergencies, and ensuring that a person's basic needs are met while in the program, such as having meals, a place to sleep, completing their ADLs. Standard 2 is probably the most straightforward standard. The medical respite program provides quality environmental services. You'll notice this is the one with the smallest number of criteria too, right? Very directive. But like other clinical settings, medical respite programs must manage infectious disease, which unfortunately we all know very well, and handle biomedical and pharmaceutical waste. Medical respite programs should follow applicable local and state guidelines and regulations related to hazardous waste, handling and disposal of materials, disease prevention, and safety. So the written policies and procedures described should reflect, again, all of your applicable local, state, and federal guidelines. I think this is one of the places that helps make the standards applicable to all programs, is that it gives you space to meet the guidelines set forth in your community, because that does vary. And really, standard 2 provides an overview and requirements for safety within a medically based environment. Even if you're not providing direct clinical care in that space, people are managing medical needs, and the space should be set up to safely be able to do that. This includes infection control, managing medical supplies, and reducing risk for staff and consumers while at the program. Standard 3, the medical respite program manages timely and safe care transitions to medical respite from acute care, specialty care, and/or community settings. So in this standard, care transitions refer to the movement of patients between healthcare locations, providers, or different levels of care within the same location as their conditions, level of acuity, and care needs change. Care transition initiatives aim to improve quality and continuity of care and reduce the chances of medical errors that can occur when the patient care and information is transferred to another provider or between settings. Standard 3 really focuses on the process of transitioning the person into the medical respite program. This provides guidance for the admission processes, including ensuring that the process is equitable and is safe. and provides the consumer with information about the program before admission, and ensures that the program has correct and appropriate information to safely support the person transitioning into respite, right? So this is, even though it's just sort of one concept of transitioning into care, it's actually a relatively complex process. The standard recognizes that the admissions process does require communication with other entities, primarily hospitals, but maybe others. But programs can help use the standard as your own point of advocacy to support your admission requirements, and especially when communicating with these partners. So for example, this helps support you if you're saying that the person needs to come with medications from the hospital into your program, that you receive the medical information at admission. This is a space where, one, you can make sure that you're providing quality services, but can also help you advocate for what you need from these partnering organizations. Standard 4, the Medical Respite Program administers high quality post-acute clinical care. So in order to ensure recuperation from illness and injury, medical respite programs must provide an adequate level of clinical care. Medical respite programs need qualified personnel to assess baseline patient health, make ongoing reassessments to determine whether interventions are effective, and determine readiness for discharge. High quality clinical care identifies and responds to the patient's needs and goals and promotes interdisciplinary teamwork. As identified at the beginning of this webinar, right, a critical component of respite care is connection to community-based and primary medical care. So although not every program may offer clinical services within their program, within their building, Standard 4 is applicable to make sure that the folks who are coming into your program are connected to and receive the necessary medical care while they're in respite to continue the recovering and healing process. So in this regard, the clinical services should meet Standard 4, whether they're provided in the medical respite building itself or in an outpatient clinic setting, perhaps a partnership or a primary care provider that folks in your community access. You want to make sure that the clinical services are meeting this standard of care to make sure that people are given the opportunity to address their medical and healthcare needs. And for those providing medical care within the respite setting, the standard can help guide your clinical practice and make sure that you're providing quality care within your program. So Standard 5, the Medical Respite Program assists in healthcare coordination, provides wraparound services, and facilitates access to comprehensive support services. So medical respite programs are uniquely positioned to coordinate care for a complex population of patients who may otherwise face barriers to adequately navigate and engage in support systems. Case managers can improve coordination of care by brokering linkages to community and social supports in order to help patients transition out of homelessness and achieve positive health outcomes. And it's really our goal of respite, right? Wraparound support services may also be referred to as enabling services. We use them interchangeably in this document. Just as having access to medical and clinical care is the critical part of a respite stay, care coordination is another of that essential component, right, that we saw at the beginning that helps support immediate and long-term recovery. So as many of us know, much of a person's health is impacted by the supports and resources they have around them. The criteria of Standard 5 outlines best practices for providing comprehensive care coordination services and different considerations to help address social determinants of health and social needs. So similarly to Standard 4, the medical respite program may not be directly responsible for providing the care coordination services, right? That may not be a staff role that you have, and you may work with a partnering organization that does this piece of the process. But also like Standard 4, the partnering organization should work to meet Standard 5 to provide high quality care. If this is something that happens within your purview, and I think most medical respite programs do have this on-site in staff, again, this will help you guide and make sure that those care coordination services are comprehensive in meeting the needs of the folks who are in your program. Standard 6, medical respite program facilitates safe and appropriate care transitions out of medical respite care. And I know this one is tricky because there's so many pieces to it and it's a complicated process. But medical respite programs have a really unique opportunity to influence the long-term health and quality of life for individuals experiencing homelessness that come into your program. A formal collaborative approach to the transition of care when folks are discharged from medical respite can optimize outcomes achieved while they're in the respite program. This is a complex process, but it is just as important as other components of a person's respite stay. So discharge can absolutely be complicated by external resources available in the community. We hear this a lot, that the goal is to transition folks into housing, but that is dictated by the resources, housing market, availability of subsidized housing in a community, and that can make that process more difficult. However, a discharge that is planned and prepared for can continue to support the positive outcomes gained within the medical respite setting. Even if the person isn't able to directly move into housing, those outcomes and recovery that happened while in the respite program can be carried forward with a structured and well done discharge. So the criteria for Standard 6 provides important considerations for developing policies and procedures to guide the discharge process. And that is understanding of there might be a variety of discharge circumstances. As with the other standards, an essential criteria is ensuring that the consumer is involved throughout the process and that they are equipped to continue to manage and address their health and social needs. Standard 7, medical respite care personnel are equipped to address the needs of people experiencing homelessness. And this is where you'll see a little bit of a language shift. This language for Standard 7 is new. And the previous standard encompassed both skills of staff and quality improvement. But in the 2021 revisions process, Standard 7 really now focuses on the medical respite personnel, both program staff and administrators. The integrity of a medical respite program rests on its ability to provide meaningful, trauma-informed, and quality services to a complex population. As such, the medical respite programs should have policies and procedures in place to ensure that their personnel, both direct and indirect staff, are qualified and effective in providing services to people experiencing homelessness. The reason that medical respite exists, one of many reasons, is that there needed to be a unique workforce in a unique setting to provide really quality care for this population. So this standard guides programs in ensuring staff are equipped to provide high quality care through training, education, support, and even the basic daily essentials such as the appropriate equipment to be able to do their jobs. This standard also addresses the safety of staff and the need for policies that can address things like racism and discrimination and any way that it might occur within the medical respite setting. This standard acknowledges the essential role of the medical respite staff in creating healing environments for those that need care. And then Standard 8, which is the language that was previously Standard 7, is medical respite care is driven by quality improvement. So you'll see this language in Standard 7 or in the previous version. However, it was developed and differentiated from providing enabling staff to provide care to kind of these two different buckets of how respite programs work. So this standard recognizes the importance of implementing quality improvement as part of the medical respite process. Quality improvement consists of systematic and continuous actions that lead to measurable improvements in the services provided in a respite program. The program develops a quality improvement plan to provide a formal process to identify measures to monitor and evaluate the quality of services. Clearly defined outcome measures and data collection are helpful to help programs tell the story of how their services have positively impacted the lives of their clients. So despite the size and staffing model of a program, again, acknowledging that there may be very large programs that have a quality improvement team, and there may be very small programs that are an initiative of another organization. Despite that, it's important to take the time to review outcomes, your successes, and your challenges faced in your program to determine what needs to be changed and what to be highlighted, right? What can you communicate with your community about what you're doing? A program needs to demonstrate their effectiveness. Sometimes it's required for funders and stakeholders to accurately depict the benefits of the respite program. And that becomes so important because once you get people to understand what you're doing, it's really critical to then show what an impact that can have. This standard also helps and includes criteria to ensure that when you're reviewing outcomes, that it's done in a safe and secure way regarding patient information and really tells the story of what's happening in the program. So now I'm going to go through and just highlight some of the updates. Because if you were familiar with the standards before, you might think these seem relatively similar, but I want to kind of just go through and explore a little bit more about what was changed in the language from the previous to the current standards. So first and foremost is really emphasizing client-centered and trauma-informed care. So one of the pieces and feedback that we got really is that it wasn't as prevalent in the previous version that client-centered care was the critical component. And so we really elevated that. Although the language was in there, we wanted to make sure that people saw that client-centeredness first in each standard in each part of the process, and that it's really important to involve the client throughout the medical respite process. And also really identifying and making sure it was clear that this client-centered process happens through trauma-informed care and is interwoven throughout the language. So there's a few spots where it's really explicitly stated, but it's that thought and that approach are woven into how the standards are written as a whole. We also paid particular attention to diversity, equity, inclusion, and anti-racism in the revision process. So in a couple of places, again, we identified specific criteria that promote DEI throughout program operations and clinical care, as well as supporting staff, and providing a little bit more direction on how can we address bias and stigma, both in interactions with clients or with staff members, but also in terms of thinking about how might that impact admissions processes or discharge policies, and being aware of where that might show up. We also wanted to make sure that there was distinct criteria to address racism and disparities that might exist more overtly, and in some places just haven't been identified within programs, to make sure that the care provided in respite is more equitable and that these processes are more equitable. Again, as I mentioned when we talked about standards 7 and 8, we really wanted to separate out quality improvement from personnel needs. So really recognizing that folks who work within the medical respite program, it requires a unique set of skills and training, and wanting to support staff in what that training should be and what that support needs to look like. It's also a response over the last 18 months of making sure that there's continued support for staff who are engaging in challenging work. And it was challenging before 2020 came, but it has become increasingly challenged throughout the past couple of years. And then again, really thinking about how can we integrate processes for addressing racism and promoting diversity, equity, inclusion in our staffing, in our training, and our operational responses. And then the final sort of shift that I'm going to point out is the language around must include versus may include. So there was a lot of really careful attention paid to determine what was non-negotiable in meeting a standard. So you'll see that language when it says does includes, must include, versus what might be recommended but not required. So again, recognizing variability in resources, we wanted to make sure that there was a certain set of standards that, yes, this needs to be in place to be met, but also places where we're providing guidance and options so that your program can sort of select what to respond to. So you'll see that in the language of may include. So really, again, trying to respect the diversity and various resources that programs have while maintaining that structure of best practices. So as you're reading through the standards, you might see some places where it says this must include, right? And then all those bullet points are part of meeting that criteria, where there's, additional training is recommended and may include a list of that. That's more to give you ideas. We hope that you'll adopt all of it, but understanding again that variability. So I'm going to talk through a little bit now about how do we apply and use the standards, right? It's a little bit of a dense document. There's a lot of criteria in it if you look through it. So just sort of want to help people get started in that process of thinking about what does this mean to me and what does this mean to my program? So the first thing is, where do I find the standards? They are available on our website. If you haven't been, there's a wonderful amount of resources there, nimarc.org, NIMRC.org. Under the resources tab, you will see the first thing that comes up is the standards for medical respite recuperative care programs, because it's the first thing that we want people to really seek out when they're looking for our resources. When you click on that, that will allow you to download the standards. So please download them for yourself. Please share the link. Please share it with other folks who you know who are engaged in respite work. But now, what does this mean for my program? I've downloaded them. I've attended the webinar. what do I do next? So the first question, do the standards apply to my program? Yes. This is a simple and short answer. The standards apply to all programs, all medical respite and recuperative care programs, regardless of how you're structured or what your staffing model might be or what your funding sources might be. These are for everyone. So how do I do this when multiple partners are involved, right? One of the things that we've referenced is that some programs are standalone and they have their own staff and they include all services, but there are a lot of really creative and wonderful partnerships that are involved in putting a medical respite together. How do we apply the standards when that happens? When you're thinking of your respite program as a whole, all parts and pieces and services, collectively, you should be aiming to meet all of the standards. So there's not a standard that doesn't apply to you based on your program model. You should be meeting standards 1 through 8. However, who meets each individual standard may be different depending on what services are being provided. So the responsibility may fall to different partners to meet it, but as together and as a whole, those standards should collectively be met. And this is an important question too, right? There's 8 standards, but I know very well that there's a lot of criteria under each of those standards. So what happens? What do I do if I don't meet all of those? Our first recommendation is that this can be a goal, right? Your program should be aiming and be working towards meeting the standards. If you're overwhelmed by the idea of quality improvement, an initial quality improvement initiative could be to work towards meeting the standards, right? Because that's what's going to help have best practices within your program. It's possible that there may not be some that are able to be met because of structures or program challenges, right? So I forget the total number. There's a lot of criteria, over 100 criteria. It is probably unlikely that every program will 100% meet every criteria in this document, right? We want to be aiming towards at least meeting 70% of those criteria, if not higher. The closer we are to that 100%, the better our services are. So we're working towards it, acknowledging that 100% is likely not achievable for everyone. But again, as I mentioned, provide an area of quality improvement, something that we can be working towards collectively. So, a perfect program would meet all of the standards and all of its criteria. None of us are perfect people, and there's unlikely to be a perfect program. So just acknowledging that it's always something to be striving for. The more we can meet, the better it is. And if there's sort of a certain pattern of ones that are difficult to meet, again, that's an opportunity to look at what can we improve in our programs and services. Because of the number of partnership programs that do exist, I wanted to go into that a little bit more about how would we apply this if we're a partnership program, right? If our services are provided and run by a couple of different organizations. So the first thing is there's probably one person or entity who is overall in charge and responsible for overseeing the program. So that's the person that's really, or organization that's in charge of making sure each of these standards is met by each of the different partners. So determine who that is, right? Who is that person? Maybe it's the person who makes sure that the salaries are paid, that the rent is paid on the building, whatever it is, the person who's really responsible ultimately for the respite program. Then each kind of program can look together and determine who is responsible for each component of the program, who provides the clinical services, who provides the case management, who's responsible for doing the intake and admission process, the transition into care, who's responsible for keeping the building clean, right? Figuring out where each of those different standards fall to allow each organization to assess themselves and say, here's how I'm meeting these. And there should be communication across this, right? So if you've divided it up, I'm responsible for 1 and 2, they're responsible for 3 and 4, it's not going to be that neat and clean, but coming back and communicating together, because together collectively, you'll need to identify solutions to meet where things are not being addressed, right? Or certain things rely on each other to make sure that you're aware and and that you could also speak confidently as an organization about where you are with the standards. So you can evaluate your own practices for the entity and part that you're responsible for, but then you can also communicate together and as a whole program and organization, think about how you can improve. So I'm going to share one example here, right? So if you were a combined respite program, perhaps the beds are located within a shelter setting. So the shelter would be responsible for standards 1 and 2, right, which are more about that physical environment piece. Standard 3, the admissions and intake process, and potentially standard 6, because there are components about being able, about how the discharge process might happen, especially if shelter staff are responsible for facilitating the discharge. You may partner with a federally qualified health center, and they might provide the care coordination services, the clinical care, right? And also have a say in the discharge process by clearing people medically to be able to leave. You may have a partnership with the community case management organization that again provides that wraparound clinical care, as well as the community care coordination, making sure they're connected, doing the coordinated entry process, making sure that there's resources to help with food and income, all of that. That might fall within that partnership, and they may be responsible for standards 3 and 4. All organizations will need to look at standard 7, right? Any organization that employs staff that are interacting with medical respite consumers and clients should be looking at standard 7, regardless of the level of support, whether it's the intake person who helps fill out a checklist when they come in, all the way to the MD who's providing clinical care. Standard 7 is applicable there. And then standard 8, again, that quality improvement piece. Each one of these programs and entities could do quality improvement individually on their own, right, with the services that they're providing. But that all comes together and combines for looking at, overall, how are we doing as an organization? Because some of these pieces individually might be great, but because it's a partnership, there's a lot of cross communication that has to happen. And so perhaps the discharge process isn't a smooth one because there's not good communication between the medical provider saying, yes, they're medically ready to go, and the shelter provider saying, yes, they've got what they need, checklist in line, they have a bed that they're moving to, but potentially case management hasn't connected them with the right resources yet, right? There could be a lot of variables. So that communication, collaboration among these partners is really critical. And that's how standard 8 is applied with all of them. And it falls on the leadership for each of these entities to make sure that these standards are met. And why is all of this important? It's complicated. It definitely takes some time and some thoughtfulness all to go through it. But we have our clients, right, at the center of all of this, who really deserve high quality care, who deserve for the process to be smooth so that they're not worried about all of this, that they can focus on healing and recovery and have the right supports and services around them. And going back to that critical central idea that the person is the center of the care and that we're addressing all of the needs that they present with. We talk a lot about this all the time, that sort of the value of respite care is that, it's not just medical, it's not just social needs, it's all of it all together. And that happens when each and every partner is looking critically at their services and working towards best practices. So with all of that, there's some things to think about. How do I know if my program is meeting the standards? As I've mentioned, there's 8 standards, there's a lot of criteria. So one of the first and not easiest, but most direct ways to do this is to evaluate through is to look at the standards and say, yes, we have that, yes, we don't. A very structured way to do that is through the organizational self-assessment, which is available on the NIMARC website. This is a structured way to complete the evaluation. And when you've completed it, it will tell you your percentage of fidelity to the standards. So it's really nice. It'll give you a breakdown to say that you meet 90% of the criteria for, say, standard 1, but overall, perhaps maybe you are at 65% of meeting all of the standards. So it'll help you figure out which standards are higher or lower. That can help you guide sort of your quality improvement efforts and where you need to look and maybe revise some of your programs and services, and helps you have a picture overall of where am I sitting with this and how am I meeting the standards and how am I doing with my program. We understand that this is a complex process and that it's hard because you may be the only respite program in your community. You might be the only respite program in your state. If you're in California, that's not the case, but everywhere else, there's not a lot of respite programs. And so it can be hard to assess, where do I stand? How do I do this? There's nobody else I can really look to for this. Please reach out to us as the medical respite team of NIMARC and the council. We are here to support programs. We can give you feedback on your organizational self-assessment. We can provide you technical assistance for specific questions that you might have. We can help you connect with other programs. Again, it can feel sort of isolating sometimes where you are. We can help connect you with other folks who are doing the work, who can provide some examples or say, yeah, this was really challenging for us. This is how we navigated that. And this can be a process, whether you're a developing program or you're an existing program. Our goal is to help you be able to meet the standards and move towards best practices in medical respite. All right, so I think we are now to our point of questions and conversation. I'm going to just take a moment to look through the chat. Thank you, Julia, for linking the standards and the self-assessment for folks. Wonderful. So organizing my screen here. So I think we'll participate sort of through the chat, but one of the first questions is just especially for existing programs, what are some standards that your program maybe has challenges in being able to meet and yeah, kind of address all of the criteria, either, you know, sort of the current version, I know it's new, or even in the 2016 version. What are some standards that maybe are a struggle for your program, and some things that you've done to help address this? And I guess I should probably backtrack a little bit. I jumped right into these questions. Are there questions on the standards itself? I will start there. So Julia, when field testing was happening with the revised standards, where did you see struggles? I think one of the biggest places that we saw people having a hard time in meeting the standards was the discharge, standard 6, discharge from medical respite piece. You know, a lot of programs had challenges in meeting certain criteria with that when we were testing, looking at the original standards and in the testing form. So that's one of the places where we spent a lot of time revising the language, I think, to help clarify what would make a successful discharge, what policies would help support that, what procedures would help support it, and to be, again, client-centered. So certainly there's the goal of the client's goals are met and they feel their goals are met. The providers are happy, the care coordinators are happy, there's a good discharge location. But this provides a little more guidance, I think, in the scenarios where not all the stars align and that doesn't happen, to help be respectful of the client experience and the client wishes, while acknowledging some of the barriers that happen externally outside of the respite program. So that was one of the bigger ones we saw, and why we spent a little more time revising and changing that language with that. Great question. So do folks have any questions just on sort of broadly on the standards themselves, or the revisions process, or some of the resources to support that? Great question, Amanda. I'm going to read it out loud for the group here. So the statement is, we struggle finding the line between providing quality care and discussing amongst our trauma-informed staff at what point we discharge patients for violations, she put that in quotes, doesn't like that word, of rules, and what our rules should be to be low barrier, but also have safety and structure. Amanda, I think that that is such an important statement. I don't know that I have a clean and clear answer for you on that, because it is such a complicated process. I think there's things that can be done in developing policies and procedures, sort of basics in terms of, you've mentioned your staff are trauma informed, which is a critical first step, right? And making sure everyone knows who is able to make decisions around discharge and who is not. When does somebody need to get called in, you know, if there was a rule violation, and sort of internally having policies and procedures about what is a rule violation? That means we need to engage and have a conversation with the client and see how we can, work towards keeping everyone safe. And really, what is a hard line between this person is unsafe, or it's going to make it unsafe for staff or other residents. Sometimes that line isn't always clear, but I think having some of these policies and procedures in place can help with having those difficult conversations and guiding people to know what questions to ask, what is, something easy that can be addressed by anyone versus what needs to bring in more of a kind of a all hands on deck sort of conversation. Yes, and Holly mentioned harm reduction. Harm reduction practices can be a great resource in doing that. And again, because respite is tricky because it is a congregate facility or there's multiple people staying in a building, making sure that everybody's safety is in mind. And one of the recommendations regarding low barrier, which is in the standards, is that even if somebody has to be discharged from the program early because of sort of an extreme circumstance, that there's consideration if they were to be referred again. And, could we take this person back in the program, given certain considerations, agreement from the client around safety. So even if there's a not optimal discharge at one point, like keeping that door open for future opportunities. So Janelle, I see your question. I'm going to come back to that one in a moment. But there is a question related to discharge. So I'm going to jump to that one to continue this conversation. But another question, do you have feedback or thoughts about navigating external pressure for discharging clients early? We have a 30-day maximum stay and have been told by partners that we should be discharging people as early as possible. Do you have suggestions on qualifications for early discharge? So what I will say is that the standard itself is not as explicit. One of the main key components of the standards is that the discharge process is client-centered, and that all care providers participate in that. So it gives an opportunity for the medical provider and the care coordinator or case manager kind of to all participate along with the client, so that making sure that the client is ready and prepared to move to the next steps. I think hopefully that the standards language will be an advocacy point for you regarding early discharge, because one of the key points about medical respite, right, is that we want stability and recovery to prevent having to get, inpatient or emergency room treatment for the same condition, right? And so I think one of the things that can be pointed to with the standard is that we need to meet these care plan goals for long-term health and recovery. Otherwise, we're going to see that cycle again. So I would say kind of diving into the language of that and using the standards as that ground point to say, our standards for care say that these are the things that need to be in place for a discharge. If they're not, we aren't going to be able to discharge them. But I'm open to other folks' thoughts if you have answers for that question in the chat as well. Man, so many good questions here. And I feel like we have so many resources on the docket to help with answering some of this. So I'm going to talk to coordinated entry as well. We do have a document coming out. I think I say later this fall, we're in the middle of fall, this winter. Coordinated entry can be a wonderful resource if you have a good relationship with your COC, your continuum of care, and coordinated entry within your community, because completing that process can be complicated and tricky, and respite might be a great opportunity for the person to do that, those initial intake appointments, gathering documentation that's required, even just the coordination of getting to those appointments can be really helpful. I think some of the trickier parts is that in certain communities, you may go through the coordinated entry process and then the person has to wait for a long time before there's any sort of housing available for them to move into. But being part of that system and getting into that system can be such a great objective to meet within the respite, and respite can be really helpful to that process. I think for programs and organizations that are connected with their COC, that process is more seamless and can help clients, especially those who have more medical needs in the vulnerability indexes might be raised to a higher point, and might be able to access resources that way. I know that for communities where the relationship is not as great, that can be a greater barrier. There are some programs that have coordinated entry folks on site in the respite program to help navigate that process. So it definitely is a relationship worth pursuing, because in the places that it works well. And especially when people understand what medical respite is and the respite better understands the coordinated entry, that's all beneficial to the client. All right, just give me a moment to look through the chat. I think there was a question earlier. So Jody did ask folks if they're just starting to develop out their data and their data collection processes. Does anyone have a good dashboard that they have developed that they are willing to share? And I think if you do, reach out to Jody through message, or you can drop your information in the chat if others are interested. I will plug that we do have a conversation around data and outcomes upcoming on December 1st through a coffee chat that everyone here is welcome to join and attend. And the nice thing about the coffee chat format, it's less formal than this webinar here today. We'll be able to share ideas and resources and information. So I will also encourage you all to join us for that conversation. Holly, yes, I acknowledge you can have a relationship with coordinated entry, and that doesn't always help prioritize your respite clients. Yeah, it can definitely be a challenge. And Julia just dropped the registration for the coffee chat in the chat here. So if you're interested, please register in that as well. And I'm going to highlight a message from Julia. We're really interested to hear that NIMARC, we're interested to hear how the standards could be used to set payment rates, either as minimum thresholds for quality or safety, or to inform tiered payments tied to program models. So if there are any thoughts from this group on that question, or if anyone might be interested in participating in a focus group on that topic. If you have thoughts or are interested, please let us know, because that is something that we are diving into. Wonderful. Yeah, so, and I'm going to sort of jump through. So we just have a few minutes left here. A couple of these questions have come up in the chat. So I want to let you all know what's coming up next. So now we have our standards that can really help guide our care. So we have, these are different ways to stay connected with us, and also different resources that we have coming out of the docket. So if you are not yet a member of the Respite Care Providers Network, please join. That will help you stay up to date with our all member meetings and publications that we have coming out. The next opportunity we have to come together is December 1st. I'm sorry, the wrong date is in here. I've done that twice now. December 1st, please join us for the coffee chat to talk about outcomes. And this will be a really helpful conversation to guide your work towards meeting Standard 8. We'll have a winter all member meeting. The date hasn't been determined for that yet, but please be on the lookout for signing up for that. And I will also plug that we have our national conference and Medical Respite Pre-Conference Institute this spring in May. Call for submissions to present at the national conference are open. So if your program is doing something really exciting or interesting that you would like to share with other healthcare for the homeless programs and respite programs, we really encourage you to submit a proposal for the conference, and more information can be found on our website. We also have a medical respite online course, which is launching next summer in summer 2022, which I'm really thrilled about, and is going to hopefully be a helpful and intensive way to deep dive into some of this information. There's going to be 8 courses total. I've highlighted 4 of the topics here that are going to be focused on trauma-informed care. We'll have a course on addressing behavioral health and medical respite, one specific to discharge planning. So I always wish the resources were available now to answer some of these questions, but to hopefully think through this sort of complicated process. We'll also have a course on outcomes and data and a few more other key topics that we've learned through the network of you all about what would be important. So look for that next summer. That online course will be available for free on our website when it does launch. And I'm sure we'll do lots of announcements about it. And then finally, one of our sort of next projects over the next coming years is going to be making a toolkit related to the standards. So this is something that we want to put together, and we want to put together thoughtfully, and to make sure that it's a really valuable resource for you all. So if you or your program has examples or resources or guidance or lessons learned that you think would be really helpful to share with other programs, and you would like to have available on our website as an example, please email, because we would love to have those resources. The best experts in the field are people who are on the ground doing the work like yourselves. And so we love sharing these examples, but we're really hopeful that we'll have a lot more just tangible examples of what this looks like for people to be able to put the standards into practice. And if you're interested again in getting updates and announcements, joining the RCPN, the Respite Care Providers Network, is the easiest way to do that. Everyone who's signed up for the network goes on our mailing list for announcements for upcoming events, activities, publications. You'll receive our quarterly newsletter that comes out, which highlights a lot of these different things. All right, so my last reminder is that when this webinar closes, there will be a pop-up for an evaluation for today's webinar. Please complete it. Again, that's really helpful for us as we continue to develop content and resources and know how we can help you guys doing this really critical and important work on the ground. So I will wrap it up here. Thank you so much, everyone, for joining us today, for listening and learning about the standards. And we are here for you if you have questions, need resources and ideas in the coming months. Thank you, everyone.